Hello, participants and judges. My name is Dr. Capece, and I am a second-year general surgery resident at Lehigh Valley Health Network. And I'll be presenting the utilization of botulinum toxin for giant omphalocele abdominal wall reconstruction, case report, and review of the literature. I'd like to thank my fellow authors, Dr. Wallace, Dr. Wojcik, and Dr. Brown, all who played a vital role in the completion of this project. So to begin, botulinum toxin A, or BTA, works by inhibiting the release of acetylcholine, which effectively prevents muscle contraction from occurring. It's also been shown in some studies to inhibit the release of glutamate and substance B, both of which play a role in inflammation. Its peak effect takes around 7 to 21 days, with the return to baseline activities around 90 days. It's been used in adult abdominal wall reconstruction as well as a number of pediatric cases, but its use in pediatric abdominal wall reconstruction is relatively novel. So our case starts with twin A, who was born prematurely at 33 weeks with IUGR and a giant omphalocele. The omphalocele contained liver, small bowel, colon, and spleen. After birth, the omphalocele was treated with dilute betadine washes until epithelialization occurred, and then it was gradually reduced with a series of ACE-RAP compressive dressings. Overall, his repair was delayed to about 2 years of age due to poor weight gain. So that brings us to an 8 by 6 centimeter omphalocele with minimal compression required for reduction. It was then decided that he would undergo IR ultrasound-guided BTA injections 2 weeks prior to repair. So this was done by interventional radiologists with 8 units each at the superior, middle, and inferior aspects of the external, internal, and transversus abdominal wall muscles. Then this was allowed to take effect, and about 2 weeks post BTA injection, and anterior component separation was performed. So figure 1A and B is showing the pre and post BTA injections, with figure 1A showing the day of arrival for the BTA injection, and figure 1B showing the post 2 weeks BTA injection. I'd just like to take a moment to stop and appreciate the spontaneous reduction of the omphalocele after the BTA was allowed to take effect, figure 1B. So figure 2A through D is showing the actual repair with anterior component separation. I'd like to emphasize here figure 2B and C, which both emphasize minimal tension on repair due to the increased abdominal wall laxity. So postoperatively, our patient did well, was observed in the pediatric ICU without any signs of abdominal compartment syndrome or respiratory compromise. He was discharged on postoperative day 5, seen at 2 and 4 weeks postoperatively, doing well, no evidence of recurrence, and a return to baseline activity. Overall family satisfaction was very high with these results. This is just 2 weeks postoperative, the incision healing well. So taking a step back, BTA has been used as early as 1980, or at least recorded by Dr. Scott for the treatment of strabismus. It's now used in a variety of different medical indications across many different medical specialties. In particular for us, BTA has increased activity in highly active muscles, which makes abdominal wall musculature a prime target. So the theory is that BTA injection decreases abdominal wall tension, which increases intra-abdominal volume, and overall allows for a reduction or spontaneous reduction of abdominal contents through a defect that's present there, which is what we saw in figure 1B. So in conclusion, we believe that this is a safe and effective adjunct for omphalocele repair, at least in our case. It did increase abdominal wall laxity, which decreases tension on repair and improved wound healing. It may decrease the need for mesh and as well as additional multiple procedures, and this might even allow for earlier closure. These are my sources. I have time for any questions.